Hi everyone, I'm Dr. Faisel Syed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care. Today, we're talking to Dr. Bill Fox, chairman of the American College of Physicians, about resiliency, empowerment, and the pursuit of rewarding primary care. Let's get started.
Hello, Dr. Dan.
Hey, Faisel, how are you?
I am doing great. Just a little bit of technical difficulties, which is so frustrating. My goodness. And I think it's great that we got Dr. Fox with us today.
I had no difficulties getting on Faisel.
He didn't have any. He probably has the perfect EMR. Probably has that AI audio, the charts automatically.
None of the above. I know how to turn on the computer and I know how to click the link.
There you go. It was nice having a doctor on who actually has all of that in her practice. And this is where we are right now in 2024. It'd be exciting to see 4 or 5 years from now some of the things that we'll be talking about, the frustrations of the next generation of doctors. But Dr. Fox, I was talking with Dr. Dan earlier, and we talk about all sorts of things. And one of the things that we talked about today, which is actually what you had brought up at the annual Primary Care for America meeting in DC, was about the payment lag for physicians over the last 10 years. I mean, if you look at everything else across the board, so far as just where things are going with payments to primary care physicians, to physicians in general, compared to anybody else in the hospital system. Primary care doctors, I don't know primary care, but probably all physicians across, it's almost 25% payment lag over the last 10 years compared to anyone else. I mean, what do you think some of the main disparities, reasons are for this disparity?
Well, first of all, Faisel and Dan, it is so great to be with you today. Payment policy to me is everything. I think it determines everything about the kind of mess we're in as a healthcare system. And so I've done most of my work in the American College of Physicians trying to deal with and understand healthcare policy, and especially or specifically, payment policy, how physicians are paid and how could they be paid in a way that makes more sense. Yes, you're correct. When you take into account inflation, payments to physicians have lagged behind inflation by almost at this point 30%.
Oh my God.
So it's essentially a 30% pay cut, whereas every other bucket of money in the healthcare infrastructure, which is hospital inpatient, hospital outpatient, skilled nursing facility, those all have increased by statute according to the medical economic index, so kind of mirrors inflation. So to me, it's no surprise that we are seeing the kind of extinction of independent practice and the trend of physicians becoming employed by larger entities, be that health systems or corporate entities or even private equity. Because obviously, if the physician in the small independent practice, if their payments don't keep up with inflation, there's really not much in the way of other choices for them.
And I think at PCFA, you mentioned, and I had the picture of you graphing it, sort of like you're graphing people's renal function and when they're going to go on dialysis. You had it graphed as to when the last person would be in private practice. Now, I think direct primary care may be making a difference there, but when was your estimate that private practice was going to be the true dodo bird?
Well, so I love that you said that. So I did give a talk at one point just to our board at the American College of Physicians, and I titled the talk "The Last Dodo Bird," because trying to graph the trend as to, 25, 30 years ago, 75% of physicians own their own practices or independent practitioners. And of course, I'm making up the number slightly because I don't have command of the actual data in front of me. And now it's about 25% own their own practices. So you can plot that on a graph. And it was something like, at this rate, independent practice for, at least for primary care, would be extinct in around the year 2032, which I also kind of amusingly understood is like a year that I had targeted retirement myself.
So you'll be able to do the talk as the last primary care physician, the last private primary care physician, right?
Yes. I mean, it's interesting. Since that time, we have seen this little uptick in direct primary care. So that may be a potential solution for the future of independent practice. That may be, one offshoot of the dodo bird. I don't know what came from the dodo bird, but probably something. And this could be the next iteration in the Darwinian gene construct of healthcare.
Yeah, it's hard enough when there are enough of the factors that are emotionally plaguing doctors. They're pressuring us that, hey, we're not feeling fulfilled. But then when you throw in the financial with doctors, we've met so many physicians who are just, their margins and their practices are talking 1.5% to 3% margin, very tight margins. So on top, and now we're post-COVID. So this is just in the last 10, 12 years.
I mean, there's so many places I could go with that statement, Faisel, but they have talked for many, many years about a physician shortage, not just primary care physicians, but physicians of all stripes. But the shortage of primary care physicians is like the largest packet of the overall shortage, something like 50 to 60,000 physicians short by the year 2034, say, something like that. 10 years from now. And to me, that's always been somewhat of an abstract construct in my mind. We're aware of it, but it didn't really impact me in my day-to-day life as a physician in a small independent practice. But ever since COVID, I think things have really changed. We've really seen the change, that it takes a very long time for my patients to get into specialty practices if they need a subspecialist, especially the cognitive specialists, endocrinology, rheumatology, infectious disease, neurology. Those can take at least 6 months. And then, of course, it takes a really long time to get into a primary care doctor, if you can get into a primary care doctor at all. In our practice, there's 3 of us, and we're not always accepting new patients, but when we are, the wait could potentially be 6 to 12 months. And we see stories. Our front desk staff tell us stories of patients in tears on the phone because they don't know where to turn, they don't have anywhere to go, and it's heartbreaking. It really is.
Yeah, I think when we hear about the direct primary care, the direct to individual and the direct to employer, we're talking about what came after the dodo bird, but that just shows the resilience of primary care, isn't it? Like that doctors, it didn't come from something central. I mean, just a grassroots, hey, doctors coming together saying, hey, okay, we know what we got to do to doctor patients. We've let the business people and let other people try to run this thing and they kind of run amok. I think it shows a lot about just primary care in general, how we can figure out ways that this is just not acceptable. I mean, we can't sustain it in this way anymore.
I think we are resilient. And if I do have a germ of optimism, and I do, it's that primary care is so valuable that ultimately I think we will figure it out. I think primary care provides some of the best value, if not the best value in the entire healthcare ecosystem. And I think based on that, you'll find that people rely on us. There's a lot that we can do. And we know that a robust primary care infrastructure can reduce mortality, morbidity, reduce emergency department visits and hospitalizations, increase overall patient satisfaction. Most patients love their primary care physicians. And as I said, there's so much that primary care physicians can do and so much value that they bring to the equation that I think ultimately it has to survive. And I believe ultimately, once we figure it out, we'll thrive in the right setting. We just need the tools to be able to do that.
Don't you think the primary care physicians need time to do the thinking rather than the administrative burdens that are on us is, the patient goes to see the orthopedist and the patient needs a hospital bed and the orthopedist says, go talk to your primary care doctor about it because they don't have time to deal with that. And it's like they generally have a lot more support staff in their offices than we do in our offices to do that. And I've wondered, I know you're talking about the cognitive specialist, but does it help to memorize? I've just had a couple of things in the last week. I saw one patient who had fallen and I was seeing her in the office. And when she was when I was checking her eye movements, she wasn't going past the midline on her left eye. And she said she was having intermittent diplopia. Now she had a CT in the emergency room already. So I wasn't terribly worried, but I went to one of the AI tools that's available, and I basically said, "What causes this?" And it told me it was a trochlear nerve palsy, and it said, "Here's the three or four things that can cause it, and here's what the workup should be." Because normally I would think, "Well, God, I got to get this patient to the emergency room. I've got to get this patient to a neurologist." And now I was like, "Okay, we know these things look pretty good, so I'm going to wait and get her to an ophthalmologist to see what's going on and order a couple of more blood tests." And then similar thing, a patient came in with a low testosterone level and wanted testosterone replacement. I'm like, well, has anybody done the workup? And it's like, normally it's like you'd ask an endocrinologist or spend 30 minutes looking it up in the book, and you go to not Chat GPT, but an AI enabled tool, and it says, oh yeah, we need to order these tests and determine if it's primary or secondary. And I mean, these things we don't do all day long every day, but I was actually able to, both times the patient was sitting in front of me, I was able to query this. And it was like, I wouldn't want to make decisions based solely on that, but I really think the ability to talk to patients and do an exam and then get information is really where the future is going to be. But we need time to be able to do that rather than filling out pre-authorizations or whatever else they have us doing.
No question. I have not used, and I would call it augmented intelligence, because I feel like it's augmenting human intelligence and human decision making. Certainly I've used search engines, I've used point of care tools like Dynamedics. Yeah, and I think all this is really important because in primary care, if you're a primary care physician, you have to know the entire universe of medicine. It's impossible. So I think we're focused on not that we know everything, but we know how to get the information we need and try to parse out when things are an emergency versus when they're not an emergency. And any tool we have at our disposal can do that. But I think, Dan, yes, coming down to your basic point, our most important tools are our brain, our ears for listening to the patient, and time. Time is absolutely vital because if we're smart, we just don't have all the facts in front of us at any given moment. But given enough time, we can solve a lot of problems and save the healthcare system a lot of unnecessary referrals and tests if we are given that time. The current payment system, the fee-for-service system that most doctors work off of, doesn't really allow for that luxury of time. It's a little better now since they revised how Office E and M codes are paid for, but there's still a lot of work to do, and ultimately it's not the best payment modality.
I remember, so when I did residency, we were the residents that transitioned from the paper charts to the electronic health record. And I remember the change with the OB rotation. So OB rotation, we didn't know who the patient was behind the door. You come up to the door and there was a plastic slot for the residents who are listening. You had a folder. You pick up the folder, you open the folder. On the left side was a face sheet, and I had everything I needed to know really quickly, with the patient. And then I had on the right side with the notes, and on each 8x10, there were 3 notes. It was 3 days of notes on, divided. And it was easy. It was just so we were able to fly through seeing patients, the routine. And I remember when we switched to the EMR, and literally it got reduced from being able to see as residents 12 to 15 follow-ups, the routine OB down to 3 or 4, because suddenly everyone who touched that paper had to find places to put data and information. And then we had to know where to find it and pull it out. And there were so many promises before we made that switch. I mean, we were excited as residents, and the attendings were grumbling, and we're saying, "Oh, you guys have no idea. This is going to be amazing." We were so excited. And then when it came, we're thinking, "Oh." And still 15 years later, we're still not there yet, although there's hope. Some of the technologies in the last year and a half, 2 years, so I'm excited. But with the inefficiencies with our system, you just said about time, I still feel like the time is still not there for us. Like everybody else is clocking their time in and out. But for us, it's just, okay, you got to get 20 hours of work in every day.
There's a recent study, and I may have talked about this a little bit at Primary Care for America, that in order to do all the work that you needed to do, the acute and chronic management, all the health maintenance, and all the charting would take about 27 hours per day. Just a simple 27 hours. Not a lot, just 27. And the same paper was trying to demonstrate that if you went down to, if you had a well-organized team-based care, it would be something more like 9 hours a day, But yes, I mean, this is one of the issues is physician burnout. And one of the big drivers of that are things like physicians becoming data entry clerks or doing what we call pajama time, going home at night in the evening after the kids are asleep, instead of trying to relax. Then there would be like another hour or two of mop-up work that you would do on the EHR. And we do know, and it's been fairly well demonstrated, that for every hour of patient-facing time, there's an additional 2 hours of time in the EHR. Now, Faisel, I wouldn't go back to paper charts. I still remember the times when a patient would come in that would need 12 prescriptions written, each one on a separate prescription pad, and my hand would be cramping at the end of that. So and I do feel that you can find some information, better in the electronic chart, and it'll probably get better as we go along. But I think physicians, missed being better influencers of the electronic health record at the beginning. And I think administrators got their hands on it and they saw the potential from their end and designed it from the viewpoint or the lens of administration and billing, as opposed to the patient narrative. The thing that's missing from those 3 notes on a single page that you saw during your OB-GYN rotation, Faisel, is a narrative. And that's what it's really important to restore. And we got to bring the EHR back to the patient narrative.
We see even with the nurses, not only with the physicians. I had to visit my cousin yesterday in New York. Sadly, he had a stroke, and I had to help coordinate some of his medical care and rehab. And the poor nurses were so busy on the computer at this great hospital in New York, and I had to end up doing a lot of the work to help him with how to swallow, how to eat. And the nurse was in and out saying, "Oh," he said, "don't worry, I'm going to chart that you're doing this, and I'm charting that you're doing this, and I'm charting." And my cousin's wife looked over to the nurse and said, "What if he wasn't doing all these things?" And the nurse said, "I used to be able to do all of that." He was an older nurse. He said, "I used to do all of these things." He said, "Now you got to call me if I got to straight cath someone, or, there's some issue that there's no way a family member could help. Like, I absolutely must do it." He said, "I'll do it." But he said, "I'm stretched so far thin. And on top of that, I've got to document so much that I just don't have time to do the things I used to love to do." So it's not only with us, but it's across the board. I can't even imagine what it's like for there's so many other, all the different techs and all the different people who are involved in the teams at the hospitals. It's just, something's got to give, and it's coming. I feel like we're here. I feel it. I feel that, we're hearing more and more. Like I said, it'd be exciting to see where we'll be, in another 4 to 5 years.
It's very interesting. I think we are at a huge transition point right now in how care is delivered. And I think that's created a lot of pain for a lot of the physicians who are practicing right now at this moment. I really do hope that we can help navigate a way through this, navigate through the jungle, so to speak, cut a path, clear a path, and so that those who come after us will have it a little bit easier than we have it.
Your closing remarks at Primary Care for America, you said we needed to invest more in primary care, have new models of care, and decrease administrative burden. What's your hope for new models? You're getting to travel a lot with your role as your chairman of the American College of Physicians this year, and I assume that means you spend a lot of time on airplanes meeting with doctors around the country. And so what are the bright spots that you're seeing as far as new models of care specifically for primary care?
Yeah. So yes, a lot of travel, racking up some airline miles this year. So I think at Primary Care for America, I think I wanted to raise the point that primary care is one of the most cost-effective parts of our overall healthcare system. And we spend woefully inadequate amount of money on our primary care infrastructure. So we spend about $4.5 trillion, a huge amount, almost 18% of our GDP on healthcare, and about, depending on the definition, 4 to 7% of that goes to primary care, despite the fact that primary care is responsible for like 35% of the visits and influences up to 90% of total healthcare costs through hospitalizations, referrals, testing, etc. And in our sister countries that may have higher performing healthcare systems, we've learned that they spend double the amount on primary care that we do. So there's a lesson to be learned. And also, before I get to your question, Dan, the ratio of primary care physicians to specialty physicians is kind of inverted in our country. In all these other Western industrialized countries that spend about twice as much as we do, almost 50% of all physicians do primary care, whereas in the United States, it's something like 20% or less. So that's part of the problem. And then, the good news about it is that there are solutions. Like, these are ultimately solvable problems. And I don't even think it's that complicated. It just takes a lot of political will. I think we recognize that the fee-for-service system simply is not working as it's intended, and it doesn't mirror the way we deliver care in the modern era. Really our healthcare payment system is probably designed for the way we delivered care 50 to possibly 100 years ago. So 100 years ago, the classic example was, a doctor came to your house for a house call. You gave that visit, the person paid you. Maybe 50 years ago, we had like the golden age of office-based medicine. So people would come to the office. And in current times, I would still say that we're driven by office-based medicine, but care is way more longitudinal. We deliver care via telephone and telemedicine, and physicians are connected to their patients through the patient portal, which really connects the patient to the physician 24 hours a day, 7 days a week, 365 days a year. We're doing remote patient monitoring. Patients are texting. Patients are direct messaging me on Twitter. All kinds of ways that we communicate, almost like it transcends time and space. So fee-for-service, care delivered in discrete parcels of time, and the payer or the government will pay you, just doesn't seem to work. So it does probably at this point come down to either a blended payment model, like a mix of capitation and fee-for-service, or a fully capitated model. And I think, Dan, that you may be practicing in a fully capitated model, like what they call a direct contracting entity or ACO REACH. And Faisel, I'm sorry, I don't know if you're actually in the same system, but I think maybe you are in the same system or just...
Technically, yes, but in transition. Yeah.
Yeah, in transition. So that gives the kind of fluidity that makes a lot more sense. Instead of, paying for every discrete show that you watch on Netflix, you pay kind of like the monthly subscription model. And I think this is the way things are done nowadays. And we just have to figure out how to transition to something like that. So that's the payment mechanism, but you still have to change the overall valuation to increase the valuation to primary care in general. And of course, finally, my final point is if you're going to do these things, you do have to account for quality in some way, shape, or form, and you have to account for severity of illness of the patient. But you need to do those in ways that are administratively simple for the physician and the practice.
He just gave a great idea, Dr. Dan. We could have the primary care subscription with commercials, which is a little bit less, and then the one without commercials, you got to pay a little bit more. And the commercials that they watch, they're going to have to end up, there's going to be an activity that's involving like an FOBT card or something depending on what.
But yeah, the commercials they watch, especially if it's employer-based healthcare, the commercials they watch are on preventive medicine, right? It's on how to eat a plant-based diet, how to manage your sugar or your blood pressure or those kind of things. So that would be pretty cool. No, and you bring up a very good point. Having the full capitation does give you the ability to make decisions, although when the government payers decide to reset all the codes and decide to cut that reimbursement across the board, that creates struggles for the groups that are doing that. Whether it be there are a number of groups going through that right now, and that's something that we again have to figure out how to. Primary care provides such value. Why are we worried about them making too much money? Why don't we give them a little bit of extra money? I mean, that's really sort of where back in, when was it, wasn't it the 1970s where they sort of changed the way payment was? They made it cost plus, so the hospitals would be getting more money, so they would build modern hospitals instead of every doctor having their own little, the little town I grew up in, there were two hospitals. One was owned by Dr. Waddell, one was owned by Dr. Cox, and they had their own little hospitals. And then they had a big, community program, and they built what we would still consider a modern hospital today. But the government was actually providing more money, and they were putting more money into the system, so hospitals would build larger structures. Now, maybe we've gone too far on that end, and that model's obviously changed to the DRG model now. But maybe we need something like that around primary care, where you're actually going ahead and pouring more money into primary care and seeing, again, putting some quality measures in place, but letting people really be creative with how to create the new models.
Yeah, look, I mean, I'll say again that I believe primary care saves money for the system, and I think that those investments would be very wise ones. I should also say I've talked about blended payment models. I've talked about full capitation. I didn't mention what I'm involved in. I'm involved in an accountable care organization. We participate in an advanced alternative payment model through the Medicare Shared Savings Program. The idea behind that is, as I'm sure your viewers are probably aware, and I know you are, if we can demonstrate adequate quality and care for our patients, if we save the system money, the government essentially splits that money with the physicians. That program, at least in recent years, has saved maybe $2 billion a year to the Medicare program. And so is a successful program showing that if you do primary care right, you can save the system money. But yes, it does come down to increasing overall valuation of primary care. And all these things you're talking about, Dan, decreasing the administrative burden. It seems like doctors face so much whiplash with all the changes that occur every year that as soon as we kind of get a handle on one way to do things, we're asked to kind of do it another way, which causes a lot of cognitive stress.
And how do we develop the AI going forward so it doesn't turn into an arms race, right? The doctor's AI fighting with the insurance company's AI as far as, and to really do what we need for patients to get the care they need. Because it seems like there's always going to be a push to decrease payments, right? To not pay for something. And how do we figure out what the right things to pay for are, and just we're going to pay for it and help people utilize the services that they need?
Yeah, it's a really good point. And AI, we're all very intrigued by how it's going to change our lives. And I still have enough years of practice left in me that I am going to be dealing with this. And, when I think about AI, I think about it on a lot of different levels. And I'll say that one level in which I think about it is AI going to destroy the world, right? Because there are some.
Let's start from the main one.
Let's start at the big picture. Because some of the deep thinkers in AI do say, yes, there's a certain percentage possibility AI will do something so catastrophic that humanity will suffer as a result of it. Okay, let's put that away. But then you think about, well, how does AI cure diseases that we haven't been able to cure? Or how does it personalize care for any individual so you can achieve your optimal health? But then as we go down further, how does AI help us in our daily lives as physicians? And some of the low-hanging fruit is taking care of all the administrative tasks that we want to take care of, like when it comes to prior auth or data entry or things like that. And then, as you said, Dan, on the flip side, insurance companies are using AI to assess whether we're coding properly. Can they pay us less than they want to? So these are going to be challenges, and we may require regulatory efforts or even legislation to help protect doctors from some of these things. I'll leave my soapbox about AI destroying the world. We'll leave that for another time.
Dr. Fox, we have a lot of students and residents. A big goal of ours is to inspire the students to pursue primary care residency programs and for the residents to pursue careers in high quality primary care working environments. Lastly, what message would you like to share with the young doctors, the young medical students who are considering careers in primary care, given even all the challenges?
Yeah, so on balance, primary care, I have absolutely loved it. There are a couple of reasons why. It's the most diverse field in medicine. You never know when you enter the exam room what is going to be behind that exam room. It's not that exam room door. It's not going to be your 10th knee replacement of the day, which you've had 300 others, in the last several months. It could be anything. And it gives you the most exposure to everything in medicine. But I would say even above all of that is you get to develop these incredible relationships with patients that you have known. And now I've known some of them for decades. And then they ask, my children are aging out of their pediatrician. They want to see, I'm an internal medicine physician. So they say they would like to see an internal medicine physician. And that's really such a moment where I feel truly honored to be involved in the care of that family and those individuals. I also feel like there's so much you can do in the primary care space, both as an internal medicine physician and as a family practice physician, because if you want to see patients and, day in and day out, you can do that. But there are also other avenues for you to use your degree and your areas of expertise. So it gives you a lot. It's almost like as a primary care doctor, you're the pluripotent stem cell, if you will, of medicine.
Well, Dr. Fox, your words of wisdom, I'm sure they're going to resonate well with the next generation of students and physicians. It's really heartening for me for us to just hear leaders like you just inspiring the future primary care physicians. Thank you. Thank you so much, Dr. Fox, for joining us today on this Friday afternoon and having this lovely conversation.
Well, gentlemen, this has been a lot of fun. I really appreciate it. I really enjoyed it. And Faisel and Dan, it's so great to see both of you again. And I really appreciate you having me on.
What are your thoughts on resiliency, empowerment, and the pursuit of rewarding primary care? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.